Good afternoon, everyone. Good afternoon, good afternoon. Hi. Good to be here. I hope everyone had a fantastic lunch and some opportunity to connect with people who you haven't connected with already. I am Dr. Letha Maybank. You all met me earlier, a proud member of the Race Forward Board, as well as Senior Vice President and the inaugural Chief Health Equity Officer at the American Medical Association. Yes. Thank you. And we are really honored to host the National Equity Grand Rounds at this Facing Race 2024. This conversation today and today's event is called Rewrite the Script, Narrative Transformation for Equity in Health. And it is the second of actually our events that we've been doing in 2024 around this. We welcome folks that are in this personal audience as well as the virtual audience all across the world. And as we continue on, I want to just give great thanks to my colleague here, Dr. Emily Manchanda, Cleveland, who has been fantastic in just organizing this along with her team, what we have here, the art that we have present throughout. Just really grateful for your work and leadership. Emily?
Thank you so much, Aletha. So this National Health Equity Grand Rounds series has been developed in partnership with the Accreditation Council for Graduate Medical Education, the National Center for Interprofessional Practice and Education, and Disability Belongs, as well as the American Medical Association. This series is a platform for critical national conversations about complex topics in health, and it's designed to illuminate some of the root causes of present-day inequities by tracing the social, economic, political, geographic, and environmental realities that shape opportunity for health in the United States, as well as to elevate the leaders, their ideas, their thoughts, their frameworks across the nation, bringing forth collective solutions. We have many collaborators in this series, and we are so grateful to each of them for their work to advance equity in their spaces and communities. So we'll begin today with a land and labor acknowledgement, which you'll see before you. We acknowledge that we are all living off the stolen ancestral lands of Indigenous peoples, which they have cared for since time immemorial. Today, we are gathered on the ancestral and contemporary homelands of the Osage Nation, Otoe, Missouri, Illinois Confederacy, Quapaw, Ho-Chunk, and Miami peoples. We acknowledge the extraction of brilliance, energy, and life for labor forced upon people of African descent for more than 400 years. We celebrate the resilience and strength that all Indigenous people and descendants of Africa have shown and continue to show in this country and worldwide. We carry our ancestors in us, and we are continually called to be better as we lead in this work.
And we understand really that this recognition is really only a first step to redressing harms as an institution and as this country. We know that our actions need to reflect that recognition as well. And we understand that we as the American Medical Association has contributions to harms and we have future obligations as well to the truths of these harms, as well as to the moments of which we've been silent. And we need to create the conditions for racial healing and transformation within the AMA, in medicine, as well as broader society as well. And all of this is actually stated within our own strategy and plan for advancing equity and racial justice at the American Medical Association. So therefore, it's important that we contribute our resources, our time. That's why we're really present here to support movement building within and beyond medicine. All right, each of our speakers this is gonna be an amazing conversation. I already see it. I'm probably not gonna have to do anything but sit back and listen. Each of our speakers has been invited to share their individual and institutional perspectives, and they may differ from the official positions of their institutions as well. So we encourage, though, everyone to be able to speak their own truths. That's important as we move forward in doing this work.
And so today, through this conversation, we hope to illuminate the ways that narrative strategy can advance health, and particularly how cultural strategies may contribute to transformation in public health and healthcare. Healthcare professionals can claim CME or CE after being a part of this conversation, and none of our speakers have anything to disclose. Part of our AMA's mission is to promote the art and science of medicine. The art of medicine can be illuminated through many media, through our words, our actions, and our arts. Art has the power to deepen our ethical inquiry into clinical practices, to document our histories, and to tell truths. It also helps us center our humanity in this work. So during our conversation, we'll have two artists at work with us. Behind the scenes, we'll be having Rio Holiday, a public health artist, a visual practitioner, who will be working to create a visual recording of the conversation that you're about to hear, and we'll share that virtually after the event. We're also joined on stage here by the Nigerian-born artist Lalu Sembanjo, who's otherwise known as Lalu NYC. Welcome. He has a background in music and performing arts, visual art, human rights law, and activism. And he'll be building on the theme, health justice is our co-creation, while creating some art here with us today.
So this is really cool. So I'm very excited to be here. And it's really a pleasure also to be able to welcome our keynote speaker, Rinku Sen, and she is an author, an activist, a political strategist, and the executive director of the Narrative Initiative. Many of you know who she is and the power that she brings. And so, Rinku, can you join? Oh, she is right here. She's ready. Join us on stage.
Thank you. Thank you so much to the AMA team, to our ASL interpreter, our graphic artist, to all of you for showing up, and the folks who are watching online for arriving. This is my home, Race Forward and Facing Race, and it is beautiful to be home. No more important place I can think of to be this week than home. I'm going to talk to you a little bit about what narrative is and why it matters to public health and healthcare workers, healthcare professionals, and to people who need healthcare, patients, families, colleagues, friends. I'm going to just start with some definitions and then hit a few do's and don'ts and then turn things over to our brilliant panel. And if it's all right, I'm going to keep my remarks focused on how we narrate the whole and narrate to groups of people, because I know that the panel will do an amazing job, much better than I could do, on how we narrate one-on-one, and particularly in healthcare settings with patients and so on. So what is narrative? Is it just a piece of jargon and abstraction that is popular today in ways that it wasn't popular 10 years ago? And will it be unpopular again 10 years from now and therefore not really worth spending our time on? In fact, when we think about narrative in everyday terms, what we often think it is the story, a story. We need a new story about health, or we need a new story about diabetes, or we need a new set of characters and plot lines and actions that happen in a articulation of a situation, a story that has a beginning, middle, and an end. But at Narrative Initiative, when we think about narrative, what we are talking about is actually a way of explaining a phenomenon, a way of thinking about the world so that as you encounter people, as you encounter problems, as you encounter opportunities, you can assess what they mean because, and the assessing of what those things mean is in fact the act of creating or interpreting narrative. So narrative is not only the plot of a movie, it is also a way of looking at the world and of elevating certain values and of discrediting other values. So at Narrative Initiative, when we use the word narrative, we are talking about the themes and ideas that are embedded, that are carried through collections of stories. One story would never be enough to establish a theme or an idea or a value. You need to be able to hear that story again and again in different forms. So if you think about rugged individualism, a value that people in the United States hold very dear and seriously hard, you will see stories about rugged individuals in everything, in every aspect of life. You'll see people ruggedly and individualistically getting themselves an education. You'll see people individually buying themselves a new house, getting themselves healthy, raising their kids. Rugged individualism appears in every aspect of American life, whether you're talking about buying groceries or going to war. So it's not just that individualism appears in public health. It gets reinforced in public health because it also appears in public education and in housing and in how we raise our kids and in sports and in the movies. So everywhere you turn as an American, you are going to get the theme of rugged individualism. You are on your own. Actually, there is no public. There is nothing we really have in common. No one's going to help you. You have to help yourself. You're going to get that message again and again and again in all kinds of forms. When a particular theme is repeated like that over, let's say, 265 or 75 years, and available in absolutely every aspect of a society, those themes and ideas become extremely sticky and difficult to dislodge. You're not going to be able to have one person, no matter how prominent they are. It doesn't matter if it's Taylor Swift or Rihanna or even Kamala Harris. One person cannot carry a narrative theme by themselves. It has to get repeated by millions of people. The reason we work on narrative is that narrative is what makes certain ideas palatable or changes the environment in which you can talk about solutions and values. So when we are trying to change policy or trying to change the practice of a particular institution, we need to have a friendly environment within which to make those proposals. And I often, when I'm doing my work, I'll ask people who are working on narrative, well, who is your audience? And they will often say, our governor is our audience, or policymakers are our audience, or the head of this hospital group in our town is our audience. But one person, especially the decision maker, might actually be the target of your proposals, the person who can grant you what you want, but you need to have a constituency of people, a community of people who are willing to argue and fight for that thing. And that's who your audience is. Activating that audience is what your purpose is as narrators. And we can all do this, and in fact, we're already doing it. We're already narrating all the time. Each time we have a conversation, each time we describe our day to our partner or our children or our roommate, each time we go to therapy. I hope folks are doing that. So when we are narrating against rugged individualism, we need to be thinking about who we can activate to move ideas of collective care and commonality. What are the stakes in health and healthcare and public health? What are the narrative stakes? The stakes right now are that people who are not well or are considered to be outside of the norm are being pushed out of the public. We don't want to see disabled people. We don't want to see people of color who are suffering disproportionately from diabetes or cancer or heart disease. We don't want to see trans people. All of these people should get out of the public view. Their voices have no place in the public. And the only thing that the public should have anything to say about through the government and the state is our reproduction. Those are the stakes. Everything is private except your reproduction. We're going to push all the issues out of the public sphere, out of public discussion, out of public view, and make you handle it individually and privately, unless it's about your reproduction, at which point the state will get involved. In fact, under this ruggedly individualistic narrative about health, There is no public, there is no commonality, and if you're sick, you are to trust no one. Trust no one unless they gave birth to you, they're your parent, or you gave birth to them, they're your children. Our narrative, the narrative that we need to move, is a narrative of collective care and responsibility. The narrative is that interdependence is natural. Isolationism is not. Interdependence is the natural state of human beings. Isolation is an unnatural state, and isolation leads to illness that cannot be resolved. If we're talking about health as a public good, a public concern, a part of the commons, no one is well unless everyone is well. No one is well unless everyone is well. If there is going to be care in the society, it has to be available to everyone, or it will become available to no one. So from shutting out all kinds of groups from the notion of a public and of commonality, we have actually built a health system on top of a foundation of racism and sexism and rampant greed. So our system is built on those values, and those values at the core of our system degrades the system for everyone. You might not be a person of color, but structural racism still degrades your system. You may not be a woman, but structural sexism still degrades your system. And that is part of the reason that Americans have lower life expectancies than our counterparts in otherwise Western so-called developed countries. So the value that we need to narrate to is people in connection and community who are able to unleash the abundance that exists on this earth, in this world, in our communities, and even inside of our very bodies. So I talked a little bit earlier about how we need to think about audiences. What does it mean to have a narrative strategy where we are moving these values forward, where we are empowering millions of people to speak and narrate to these values themselves? The first thing I want you to think about is that narrative change and narrative strategy does not go policy by policy. It goes idea by idea and audience by audience. So if your idea is unpopular right now, you need a longer-term narrative strategy to bring it into the public realm, to bring it to people's proportions. When we are, all of us are talking about the problems that we're trying to solve in the society, we tend to need to talk about three things. Why the problem has become a problem, what caused it? What is the solution, and how we're going to get there? Proportionately, most of us, in our 3 minutes of conversational time or our soundbite or our, op-eds, we spend 90% of our time talking about the why. What has caused this problem? What are the systems? What are the corporations? What are the laws? And 90% is analysis. And we often look to people to agree with our read of the cause before we will accept them doing any action, before we will encourage them to take action. But the danger of spending 90% of your narrative real estate, let's say, on the cause and the analysis is that we actually wind up depressing action. People might believe us. They might believe that unregulated corporate behavior in the healthcare system is the cause of many of our disparities and of people becoming ill and not being able to get better. They may agree, they may accept what you're telling them as how the system is set up. But if you spend 90% of your time on why the system is bad, and you give then 5% to the change we need and 5% to how we're going to get there, people will believe that the system is bad, but they'll also believe that they cannot do anything about it. If they could do something about it, you might have spent more of your time talking to them about what they could do about it. I want you to remember those proportions. Try to reverse them. Try to do 90% of your time on the what and the how, what we want and how we're going to get there, and just experiment with only 10% of your time spent on the analysis and the why. I want you to remember that narrative, the purpose of it is not just self-expression or argumentation. It is recruitment. It is inspiring action. It is building community. Those are the purposes of narrative. And it's really hard to tell people of science that facts don't matter, so I'm not going to tell you that. I'm going to tell you facts do matter, but they matter less than you think they do. They matter less than we wish they did. What matters more, very often, is trust, confidence, respect, a sense of belonging, autonomy. The fact that in dealing with public health, we have come to call what is propaganda misinformation and disinformation, as though information has anything to do with propaganda, which is what we're getting. That reveals our slightly pathological, shall I say, attachment to the facts. I do not want you to myth bust. I just want you to lead with what you want and how you're going to get us there, how we're all going to get there together. If you bust myths, we are just going to reinforce the myths. I don't want you to berate people for not doing what you think they should do. Instead of asking, how could you do that? I would prefer that you ask, why did you do that? How could you do that as a judgment? Why did you do that is a question. People have said to me that we will survive another Trump administration. We survived the first one. We will survive a Biden administration. We survived this last one. But you know, as well as I do, that we didn't all survive it. We didn't all survive the last 8 years of presidential administrations and of White Houses. A lot of people died. Many, many, many people died. Our grandmas, our uncles, our children, our besties, those are the people who died. And many other people, additional people, were left with a version of life that you could barely call living, an isolated life. We are their witnesses. The people who died are not here to tell us anything about that. We are their witnesses, and someday people will be our witnesses. Our job as narrators who care about justice and equity and public health and sustainable life, our job is to witness in ways that invite action, that inspire people to do the next thing. In our case, to narrate differently than we might be used to narrating. In other cases, to build systems that we haven't actually been used to building. We can rebuild the public. We can rebuild a sense of commonality between people who are very, very different from each other. We can rebuild a commitment to all forms of justice. And we can convince people that annihilation is not inevitable. We don't all have to die. We can convince people, if we are convinced ourselves, that a healthy future is possible, and that the way we get there is together. Thank you so much.
Thank you, Rinku. That's a long walk up that ramp. Okay. Thank you, Rinku. Thank you for your words. Thank you for the descriptions, the definitions, the connection and linkage to why this is important from the context of health and healthcare, and for us who are in this justice space at the same time. So we're going to take the conversation a next step further, and I'm going to welcome our panelists to the stage. As they are coming to the stage, though, I'm going to go over and talk to Laolu real quickly. welcome. All right. I don't want to interrupt the line that he is drawing. So, can you talk to us for a few seconds? Okay. Awesome. Well, one, thank you for being here. Awesome to have you in this space. Can you just speak to, what are you creating and what's the inspiration as it connects to health especially?
It's just my perspective of how this affects me. I would love to be seen in terms of healthcare. As a Nigerian born, also living in the U.S. now, U.S. citizen, I feel like, there's a lot of disparity when it comes to how women are seen, how men are seen, how people of color are seen. I'm just here to just draw attention to a few details with art, and just, start a conversation. Yeah.
And a conversation you're absolutely starting. And for those who want to see more of the creation, he's going to continue to stay on stage during this part of the conversation as well. But he also is located in Hall 4? Hall 4, that's right here. And you can also see and experience and talk with him as well. But really, thank you. Thank you for the work that you've been doing. It's quite incredible. Thank you. Okay. Okay, so joining me, and I'm going to sit down. All right. Hi, everybody. I'm very excited about right now, just so you know. To my immediate left here, we have Michelle Browder. She is an artist, founder of I Am More Than, an initiative, and More Than Tours. Michelle redefines women's health narrative through the impactful work of art. She has an amazing, amazing monument, the Mothers of Gynecology in Montgomery, Alabama. I've been to Montgomery, Alabama more in the last 2 years than, I was going to say Antigua, my home place, but that's not true. But I've been to Montgomery a lot as of late, just because of the importance of what you are doing. So thank you and welcome. And her work actually is also up the elevators here in the space. And she has a whole exhibit, so it's wonderful. Next to Michelle is Dr. Garth Graham. He was a cardiologist, a research, a health equity, and public health expert. He right now serves as director and global head of healthcare and public health at Google Health YouTube. And he has had many senior roles in a couple administrations. I'm going to talk about that in a second, but also at CVS Health and was president of the Aetna Foundation at one point in time as well. So thank you and welcome for being here. And he traveled the whole way from Tokyo. So he's just getting off a plane, so thank you for being here. Then we have Dr. Marette Mendefro, is a physician and a filmmaker, physician out of my heart, to be a filmmaker, the founder of Truth Aid Impact, blending art and science to tell stories that address barriers to well-being, and an Emmy-nominated producer and writer. Her work spans TV, films, documentaries on Netflix, and actually was screened, and she didn't realize until she was here, Cost of Inheritance was screened here a little earlier today. So if you all have not seen that film, very important film, please check it out. And then we have Bayard Love, known as Bay for short, is an organizer and partner at the Groundwater Institute, where he supports major client engagements, does lots of training, engagement around equity, white supremacy, all kinds of areas in the spaces that are very important to many of us. To really educate people on what these narratives are and what to do about them and how to do it collectively, I think is really important. But also in his history, helped to establish a federally qualified health center post-Katrina in New Orleans. So welcome to you all. Thank you for being here. All right, so to start this conversation, I have a series that we started at AMA called Prioritizing Equity, and I usually start off in just asking everyone, really, how are you doing today in this space? Do you have any reflections on what was said earlier? And you can talk about that later and bring some stuff up as well. But I just wanted to give the time and how are you doing right now? Michelle, how are you doing? And we'll go deep later, because I know you can get there very quick. Okay, go ahead.
I'm good. I'm striving. We come from a people that strive, and we're resilient, so we're good.
All right, great. That was real brief, but go ahead. Go ahead, Garth.
Yeah, The conversation that we started earlier was just so inspiring when we start to really get into this issue of narratives and narrative building in health. We don't talk about that enough. And it means a lot to our patients, and it means a lot to our community because it's how people understand a lot of the messages around health and public health and a lot of things we want to say. So you ask how I'm doing. I'm excited to be a part of this conversation. Just even watching an artist while they were speaking is just so unique in terms of understanding and the different ways you can translate a message. So for me, I'm excited to learn, to continue to talk about these concepts, and then more importantly, I think it's a good time in public health to talk about how we build strong narratives around health and public health.
Thank you.
I feel very energized. You know, this is when artists go to work. This is kind of what we live for. So I feel very energized, and I'm really grateful that you've curated this panel so beautifully, Aletha, for holding the space. So I'm grateful for that.
Yeah, thanks, Aletha. I came here feeling apprehensive about everything that's going on. You know, I think there's a lot of unknowns that we've still got to figure out. But I was feeling deeply that we really do stand on strong shoulders. As people were speaking about the ancestors, you know, that made this possible, I think that's real, you know, so to come right after Rinku just now and know that the last time I was at this conference was a decade and a half ago, and to just see and feel how much this has grown is extraordinary. And it was incredibly enlivening for me to be able to see people, see all of what this is, you know, sit on this panel with people. So I'm feeling apprehensive, but also enlivened, you know, by this community and what we can do.
Fantastic, and thank you all. I'm feeling energized as well. And I even as the overall conference of Facing Race, what I know is a time where we're coming together, and some of us haven't seen each other in a long time. Some of us have never met, right? Because we've been virtual. But to be in community with one another at this time is absolutely critical, and it's a space where, you know, we're able to kind of be and let down, and I appreciate being here for that. So, Marette, and is it okay I call you Marette? Okay, good. Can you just tell us about your journey, right? And your journey as a physician, and you may want to say a little bit about that, but just your journey as a filmmaker and a physician, and why narrative and cultural strategy as a way of being as a physician? What did you learn that pushed you in that direction?
Yeah, it was not at all what I planned, right? I wanted to be a physician scientist, but what it became very clear to me during residency is actually the best physicians, what they do is read the body like a text and tell a story about it. That's literally what you have to do as a physician. It's very close to what you do in that encounter. And I think when you do it right, meaning you listen and you get the story right, that builds a foundation for trust, right? Which is what's sorely lacking right now all around. And so it's very clear to me, like I gravitated to that. And the more I did it, the more I liked it. But more importantly, it was also very clear to me, you write a paper, 10 people read it in a journal. No shade, but you know, or you can make a film and TV shows, and it's a very different kind of conversation, and you have to pick who you want to talk to in this life. You can't talk to everyone all at once. And I was very clear that I wanted to talk to the people. You know, I cared a little less about my colleagues in that way, right? And we've had many candid conversations about how hard it is sometimes to talk to certain kinds of populations. So I think stories are how people learn. You know, it's how people feel connected, and more importantly, how they find meaning about what matters in their life. And this is profoundly foundational to health, right? In healthcare, we talk about activating people, patient activation. We have all these technocratic terms, right? But you've got to ignite intention in people, right? And I think that's what imagination and stories do. So I just said I decided you didn't have to be sick to talk to me anymore, right? So I became a filmmaker. But it was very much through the work. I mean, you know this, you've known me, so yeah.
Yes, thank you for that. Bae, so Bae, I've known you, I don't know, a long time. And I've met you in the space of the work that you do. And really when I was at the New York City Department of Health leading this work up, starting the center there, really started to get grounded in the different folks who were doing this work and leading, educating people across the country. And what I noticed about you, it's just like this space here. It wasn't just exclusively healthcare that you engaged with, but what I noticed, and I think we had some influence in that, is that more and more you were engaging more with public health and healthcare folks. And just curious, like, what have you learned? And your father's a physician as well, if I remember the story right. What have you learned in terms of, narrative in the healthcare space? What's different as you interact with healthcare folks across this country in doing this work?
Yeah, no, I appreciate that. And it has been such a great journey. When we met, you were doing exactly that, setting up center, building. And I think one of the things that drew us close to you was you seemed to understand what we have come to believe at the Groundwater Institute, that anybody who's trying to make change happen in an institution or in a community needs to build a coalition of people who have enough of a shared narrative, as Rinku was saying, about what the problem is, what's the explanation for what we see. There has to be enough of a shared narrative in that regard for people to be able to work together effectively. Right? And so that's a lot of what we've tried to do as the Groundwater Institute. And, I could say that it's mostly white physicians or healthcare people that aren't aligned around narrative, but I don't even think that's true. I think it's cross-racially, not even people of color necessarily thinking about causes and conditions the same way. And so that's why we think the work is important. And to me, what I've come to feel is that it's not as complex as we make it out to be sometimes. That there are narratives we found that people walk around with that are incredibly counter to our ability to make structural change. And I'll give an example, and this is one that we take on in our work a lot, and that is the very simple idea that most of the decisions that we make aren't based on conscious logic. They're based on heuristics and mental shortcuts, right? So what does that have to do with racism, and what does that have to do with healthcare? Well, it has everything to do with it. Because if I come and show a physician or a clinical administrator racial disparities data, it's like that gets interpreted as, are you calling me racist? Because we walk around with this narrative, right, that if we create an outcome, we must be doing it consciously. So it doesn't sound like a narrative, or it doesn't sound like a racial narrative per se, but just communicating to people, all of the action that you take, all the action that I take, isn't out of some sort of conscious belief or value system. It comes from how I've been socialized, and my brain does that stuff automatically, right? So, and we could just go through narratives. Another one that we really harp on is that when we look rigorously at the data, that socioeconomic difference doesn't explain the racial gaps. That there are racial gaps. When we control for socioeconomics, there's still racial gaps. Now, that sounds basic. But what we see over and over and over as we train, people by the, 25 people rooms, 100 people rooms, is that's like, wow, people can't believe it. Because somehow unconsciously, people think, oh, the difference between African American people and white people really is that white people have more wealth. But if we look at it, it's not true, which tells us something about the nature of the problem, right? And then there's more specific narratives. And these are all, I consider this to be, and we consider this to be narrative change, because once those building blocks are put into place, you're not saying I'm a bad person because racial inequity shows up in my practice. You're saying my brain is functioning the way that it's supposed to function. Brains are supposed to take shortcuts. And if you live in a world where there is racial inequity everywhere, your brain and the society is going to give you some explanation for why that is. So we have to undo that. We have to undo the idea that it's all socioeconomic and not race. And then there's things that are like set up specifically, narrative pieces that are set up specifically to undermine this work, like
we're gonna get to some of those. We're
Okay,
gonna get to
hold
some.
on
Yeah.
the health ones. Well, I appreciate that.
We're gonna come to that in a second.
Yeah.
Be ready. Just like be ready.
I'm ready. But that's it, and look forward to getting into the health stuff too. Thank you.
Yes, thank you. So Garth, and is it okay? I already called you Garth, but is it okay that I do that?
Garth,
okay.
please.
So I my
That's
entire
true.
career.
When we were so small.
When we were so small,
that's
right. I was founding director of the Office of Minority Health in Suffolk County in Long Island. And so I'm here starting an office from scratch. This is my job straight out. I'm still in residency, actually. I was offered this role to do while I was still finishing residency. And so I'm trying to figure out, what does it mean, one, to start an office within an institution, and then what is the work that I am to be doing? Because at that time, there weren't many roadmaps, strategic plans, anything as it relates to doing and advancing equity. So Garth was positioned at the federal administration, and he was director over the National Office of Minority Health. And so I looked to him oftentimes, looked to the work that he was doing to kind of really set the foundation for what I needed to do. And then we hadn't met each other until I started this job in person, truthfully. And this was 5 years ago in starting this job. You were in this seat moderating, and I was sitting where you were. And at that time, I was under the leadership of Dr. Mary Bassett. So Dr. Mary Bassett put forward lots of the work and talking about racism explicitly within the context of public health. So that's my training, right? And I had no problem saying the word racism because that's what I was to do. And so your question to me was, so how do you talk about racism in this way, in the context of healthcare? So I remember that moment, and now that you're at, YouTube, global, huge communicator, just wanted you to kind of reflect on that kind of transitioning over time and kind of where you are now, and what does this mean in terms of this narrative communication work in healthcare?
Yeah, it's so beautiful sometimes to
put this as
think
close to
through.
your mouth as you can.
There you go. It's so beautiful sometimes to think through life trajectories and how we learn from each other. Because I remember learning from you, and we've learned from so many other colleagues. Daniel Dawes, who's doing great things in Mehari, and all different kind of folks who've all kind of cycled through our passions and delivered on our passions and worked hard on things that we care about, particularly issues around community health, healthcare, disparities in health, and everything there. So for me, it's actually reinvigorating to have these conversations and kind of remember the journeys that we've been on. I have been through various iterations of how we tackle this challenge around health equity and health disparities. Right now, as we think through the concepts, it's important for us to understand, again, the lens that people are receiving information through. So part of the thing that you alluded to was this idea of, again, narrative building and how I've kind of seen the narrative evolve. And I remember, as you were remembering when you were in training, I remember in training, oftentimes, we prescribe medications for patients. I still practice medicine now, and, a lot of times we as clinicians talk to patients and we tell patients things, but do we know if they really understand it? Do we often understand what they're going to do when they go home? And this idea that the majority of healthcare occurs outside of the doctor's office, out in the communities, I think was driven a lot of my work, I think driven a lot of your work and a lot of the work of others here. And I love your comment about how technocratic we are in healthcare, because we deliver healthcare in a technocratic context, but people receive it in a personal way. And so for me, this idea of where we are now is a lot around delivering narratives to people that matter to them, understanding the communities, understanding where people are getting health information, understanding that they get health information from many times online. So, you wake up in the morning, you may have gone to the doctor's office and the day before or even earlier on, and you've had either a diagnosis or a piece of information, and you wake up and you wonder what to do. And you pick up your phone and you start this health journey, and you watch videos and you read information, and you kind of decide to do what's next. And so it's important, particularly when we think about public health and healthcare, to be where patients are, to be there in terms of delivering information to them and doing it both individually and at scale, as you alluded to. So part of my evolution right now as both an individual professional and working in public health is this idea of getting information to people at scale and thinking through the narratives in which we do that. So how do we make sure that the cultural context of which you're receiving information is the cultural context in which you live? So I'm not speaking at you or speaking to you, but speaking with you. And the dyad that you articulated earlier is this idea of how are we both involved in your healthcare as I communicate with you. So I think a lot of that is just the evolution of both public health and healthcare. And I think where we are now around this concept of public health building and narrative is really about reaching people where they are at scale, but also reaching them in a way that they understand it and speaking in language and tones that not only resonate but mean something, so we're doing their healthcare and delivering healthcare collectively together.
Thank you. And I'm going to come back also to you, to talk about just the context of misinformation, disinformation, and what do we do now to kind of be protected? But we're going to come back to that in a second. Michelle, how are you? Good. So Michelle, I met 3 years ago, I believe. And I was with a colleague of mine, one of my team members, Jocelyn Sargent, who's director of our restorative justice work. We were invited to Montgomery, Alabama by the Equal Justice Initiative, who was convening healthcare leaders to come visit Legacy and some of the other work that they have down there, the National Museum of Justice and Peace. And Jocelyn, there were a few articles that came out about the work that you were doing in Montgomery, Alabama, and Jocelyn suggested, let's walk down the street because I heard it's just down the street. So we walked down the street, like maybe 5-minute walk, and next thing you come across, and if you haven't seen it, definitely just take that escalator up outside in the lobby here. But we come across these magnificent, just kind of bigger than life, like really awesome in its awesome sense, monuments. There was nobody at that time like in the space, so we were just looking at the outside, and the next thing I see somebody come out with some red glasses. And we were able to go inside. You introduced yourself, and you asked, who am I? And I said I was Aletha Maybank from the American Medical Association. And what did you say?
Shut up.
That's exactly right. And so I was standing, and we're going to connect these dots, but I was standing at the point, I think then, where there's a plaque, and you can describe it better, but one of the former presidents of the American Medical Association was J. Marion Sims, who many folks know more of the history now, considered the father of gynecology, and also very much known to have done procedures on women who were enslaved without anesthesia when it was present at that time. So I met Michelle, and at that point, and so Michelle, can you just tell and share the story of why is it that you do what you did, and why these monuments, in terms of a narrative strategy and a cultural strategy to help impact and influence those in health?
Well, I live in Montgomery, Alabama, right? And this is where J. Marion Sims spent a lot of his time. And first of all, let me just digress, because, I got to be y'all doctors and everything. I feel a little intimidated being up here. I'm an artist, I feel more commonality, even when he's a lawyer. But anyway, you got a lawyer over here at the end, he's an artist, you got all these medical folks. I'm an artist and an entrepreneur and a dreamer. And when you came down the street, when you said American Medical Association, I did my research on the American Medical Association because of J. Marion Sims, whose statue, by the way, still stands at our state's capitol, downtown Montgomery, Alabama, that was built in front of black folks. Black people built the building, and he's still there. And so when you said, that you were the AMN, I was like, she black, though. How'd that happen? Where you coming from? And so, but my work is because of the iconography in our city and what our city in Montgomery, Alabama, red state, what that means to black people that still live there and travel on streets that named after Jefferson Davis, Robert E. Lee. It's triggering, right? And so I said, well, I want to do something about this, and hence decided to use COVID, because I ain't got no man, I ain't got no children, and I was at home talking to myself. Don't judge me, because y'all were too. One time for the people in the back. But anyway, I decided to create this monument to honor these 3 girls that were used as medical experiments during the time of enslavement. So that's what kind of thrust me into this work.
And how has it been? What have you learned about the health space and narrative and what's needed since doing this work?
There's a lot of cutting away. There's a lot that we have to do to change the narrative, even around maternal health and just healthcare in general. My sister is somewhere upstairs. If y'all see her, give her a hug, because just recently we nearly lost her because The doctors simply didn't want to lay their hands on her. They didn't want to touch her. They didn't want to put the stethoscope up so they can hear her heart, and just give her the help that she needed. And we wind up having to airlift her to Birmingham. And so what I'm learning is that, it's a skin problem. It's an issue with empathy, dignity, and respect for patients, for zip codes where people live, and how we've been marginalized and, kind of characterized as a problem, right? So this whole displacement of, or not having access is very real. And I'm still learning this as we go through the process of, the maternal health crisis that we're in today. And now we're in a health crisis because my sister has health insurance, right? She's got the Obamacare. Thank you, Barack. But anyway, we got a little bit of insurance, but it wasn't enough to save her life, right? It took a Mexican doctor to say, something is wrong, I'm gonna get you out of here, and it saved her life. So empathy, dignity, and respect is what I'm noticing that we're missing from the field of healthcare by itself.
Thank you. Thank you very much. And thank you Michelle's one of those folks who gets something done, something is in her mind, and she's gonna get it done. The amount of effort, fundraising you have done is tremendous, and it's really something to look at. Marette, going back to it, it's building off of this a little bit and how you've utilized film to move people and to move health folks. Because I remember watching one of your first films and just being so inspired by the context. There was a circle and folks were sharing and women were sharing their stories. How do you think why do you think that is important? And how do you think that that can be used and translated today within the context of our healthcare and health systems?
It's a complicated question. Look, I think we all have to get comfortable with what we don't know and understand that learning is a lifelong journey, even for doctors, right? And it's really interesting within the context of medicine, personalized medicine, the explosion of medical knowledge. I went to Harvard Medical School where we had case-based learning, and the whole kind of pedagogical framework around that is we were never gonna know everything, right? So what you had to do was figure out how to learn. And I kind of feel like it's the same frame we need for some of these harder questions. I think as a whole, it feels very unsafe for people to admit what they don't know. And I think storytelling, films, media in particular, I talk a lot about my body of work as audiovisual medicine, is about creating a shared space where everyone's experiences can almost be level, so to speak, and we can find out what you don't know, right? And so I think that's where there's really nothing like storytelling. I think it can show you what you don't know, And I think as a group, doctors obviously are so responsible, and it's very important. It's a technocratic discipline, obviously, right? We are literally dealing with lives. But I think it's profoundly important to stay humble and also recognize, right? Two truths can be true at the same time. You can be an amazing physician and still have room to grow and learn, just like you can be an amazing human, right? And I think that's so much of what we're wrestling with. And certainly when we think about equity and disparities, the problem is, we can publish papers, we can talk about it. It's what Rinku was saying, right? What I say is we pluck the low-hanging fruit. It's already on the ground. We put it back on the tree, then we pluck it, say we can pluck it, and that's how we keep moving forward. So all we do is get better and better at the wrong things, right? And so I think we have to have an introspective moment, and there needs to be safer ways for physicians, especially the ones that are teaching this stuff, right? To say, you know what, I made a mistake there. How can I do that better? And that's where I think media and storytelling can create a context of experience beyond your own horizons, where it's not as personal, and you can see yourself in that. So I think that's kind of the heart of it all.
Absolutely. And in building on that, for you, Garth, and kind of to what I was saying I was going to come back to, what are ways and how can a platform, and can you talk about the platform of YouTube? Because it's, I don't know anybody who doesn't access YouTube or Google, right? I'm sure you have stats. I'm curious to what the stats are around that, because I don't think we are knowledgeable about that. So that's one question. But then the other part is, how is a platform like that, how can it be, and what has been your strategy to be helpful to health providers and other folks, and not just physicians, but anybody who's in the context of healing and health?
Yeah.
How, what have been your strategies to be helpful to us?
Yeah, so a couple of things in terms of even breaking down an answer. So you're right, YouTube is a large platform. It's the second biggest search engine in the world and the number one place that the world comes to for video. Over 2 billion people around the world use the platform on a regular basis. I often say there's only, 6-7 billion people in the world, so it's like upwards of a third of the world population. And so for us, being able to work on issues around healthcare and public health globally is just truly amazing, because we're able to see how information changes lives, again, across the world in different cultural contexts, different communities, different languages, and in different contexts. And so when we think about it, we think about a couple of things. We think about this idea of how do you take information outside of the journals, outside of the textbooks, and into living rooms, conversations, walks that people are having where they have a question and they pick up their phone and they want to watch a video and get and understand an issue more. Or you're sitting on the couch with a significant other or family member and you have a question about something you read or heard, and then how do you take a journey through video in that context? So we take this idea very seriously of the patient journey, and then what are the kinds of information important? So it's definitely important that the information be based on evidence and that concept of science, but it's also important to be engaging so that you understand it, that it's culturally relevant to you as well. So the journey that we've been on is just that, how do we transform public health, healthcare information around the world at scale in a way that is, going to be based on evidence around health and public health, but also engaging and reaching people where they are. We started using this term, information is a determinant of health, just because information plays such an important role in the way that we understand the world around us and we understand our own healthcare and public health. So for us, it's about engaging a diverse set of voices to really bring people in and understand this whole idea of information that we take it out of ivory towers and take it into people's hearts and minds. With that being said and done, it's important that public health evolve. It's important that healthcare information evolve to, again, kind of be where people are. I often say sometimes, gone are the days of flyers and billboards. Remember, when was the last time you wanted an answer to a question and looked for that piece of paper that somebody gave you many, many months ago to find that real answer? Or when was the last time you were like, I never knew that. Oh, I saw it on a billboard. Let me drive back around and then read that billboard again. No, you walk, you go, I want an answer now. You pick up your phone and you start a long journey. You do it, I do it, everybody does it. And so this idea of health information dissemination and the active way in which people get it is evolving, and we need to be a part of that evolution. So the work that we do is about creating health information, working with folks who are creating health information at scale to reach people. And the last thing I'll say on this, the fascinating thing, just this year, as we were, I've been in so many different places and watched that evolve. I was in Brazil the other day, and in South Korea earlier on, and we see just how dynamic this issue of healthcare information is. And in Brazil, you see the Brazilian government, when dengue is attacking the country, using the voice of not just the healthcare officials, but the healthcare, the community healthcare organizations, and bringing it into soccer, football matches, and being where people are. So we have to understand how we evolve more on public health and how we make the healthcare information more dynamic. And so anyway, that's a lot of the work that drives us. And as you can see, it's a lot about the work that I'm passionate about. Last point I'll make on this. The evolution of tackling a lot of our challenges around health equity is not all about information. There's a lot about access. There's a lot about how we make sure people can get healthcare and understand some of the challenges that are based in how health equity got there in the first place. But there's a component of community empowerment that relies on us to reach people where they are and give them the right information for themselves so that they can make those decisions.
Thank you for that. And I would imagine as we are in this moment of time, that becomes even more critical, because we were having conversations about, inside, whether you're inside institutions or outside institutions working, what is this context of building? And I heard, earlier there was kind of a quote that if we don't kind of stop just looking at what we're fighting against, it's hard to figure out what we're fighting for, or even having the space to fight for. And I feel that the contribution of information and people having access to it is really critical for that building. It's not only technology, right? It's also our networks of just how we're here, of how we learn information. But I would feel that's an important piece as well. And so as we move forward, if y'all have anything you want to say or add, please feel free to do so. The panel is open in that way. So, Bae, we're going to go back to these narratives, and I want your reflection on them. This is part of the work. Narrative, I feel, is that touch point that becomes a touch point for many folks, because narrative is where power is, right? And when you have narrative, you can control, to all the things that you mentioned, really control how people act and move. And so while early on, myself and my team really felt, along with our partners over at the American Association, or the Association of American Medical Colleges, their Center for Health Justice, we partnered to create an equity narrative guide to help support just unearthing what are narratives and what are they. And so some of the ones that we come across, and this has already been mentioned already, in terms of individualism, the self-determining individuals make right or wrong lifestyle choices, which renders the political and structural kind of social invisible. And we understand in public health, I understood this more and more when I was at the New York City Department of Health, rooted more so in neighborhood, that the context of people's decisions are based on whatever is proximate to them. We could give all good advice, we could say eat good vegetables and all these other things, but if things just aren't there, they aren't there. Othering, we heard a lot of that late. Cultures of poor people and historically marginalized groups are responsible and blamed for their own poorer health outcomes. We have the myth of meritocracy, that folks, it's about this pick ourselves up by our bootstraps conversation, knowing that there are people who work 2 to 3 jobs, good standing individuals, and aren't going to have as much wealth as other individuals will. Our context of American exceptionalism, nothing wrong with having pride in being an American at all, that's good. But the context that we are superior or better than others is a challenge, and especially a challenge when we look at healthcare. I mean, life expectancy, for all industrialized nations, we are doing the worst, whether it's life expectancy, maternal health outcomes, or even infant mortality, which is on the rise. So our exceptionalism definitely has to be questioned. And then the zero-sum game and the nature of that. And then last, I'll say the hierarchy of human value based on skin color, with white being considered supreme, or gender in the context of patriarchy and sexism, or physical ability in the context of ableism. So, I want these narratives, they're there. What have you done, and what do you do? You were about to say something a little while ago, so I'm going to bring you back to that moment, but I just wanted that time to kind of go through them with a little bit more specificity.
No, it's great. And that's a lot of narratives for us all to address, right? But as Rinku was saying, they're all over the place all of the time, and they sort of weave and knit together. So all I can really share is what we've learned through our work, and that is, one of the insights that we had was that I used to think that if I could just show people data that showed there was racial disparities, that would solve the problem. Because I'd show, wow, white people are, this time's, less likely to die of diabetes. Or, when COVID came out, if you were black, racially classified as black, you were something like 20 times as likely to die of COVID. And I thought for sure, Michelle, I said, that's it. That cat is out of the bag. That's got to be structural racism. How could people see it any other way? But what we've come to believe is that showing that there's racial inequity really doesn't get us to where we need to be. We need to have a conversation about why there's the racial inequity. Because if we just show that there's racial inequity but don't answer the why question, people just fill it in with those automatic responses. And the whys are all those narratives that you said. It's like, well, why do white people have better outcomes? Because they work harder, right? Should we close the gaps? No, because it's zero sum. And if we try to bring, black folks, indigenous folks up to where white folks are, it's going to be a loss for white folks. So I don't know, that's just one thing that I would say. And I think the work about explaining the why, it has to be on all of us. Because like Rinku said, it can't be just one person that says it, can't be one book that articulates it. It's got to be messages that are repeated messages that are challenged over and over and over again at scale. But if we have that why question, I think it starts to change everything.
And I would push in, and I'm going to have Michelle respond to this, even a little bit more than that, because what I've learned, and I'm in full agreement, numbers don't typically move people in that way. And I've learned that, and I've found that many folks will disassociate themselves from the context of the problem, even when they see the data, they understand the roots of it to some level, they will disassociate. I'm going to say within healthcare, and I'm going to say physicians because that's who I'm around. What I've found in terms of where the movement has happened has been some emotional jolt or push, and that has happened at the intersection of storytelling. That's when I've seen when the spirit softens. We're proximate and close to each other. We're here. I mean, that was the great opportunity in some of the trainings that you offer, that we're hearing the stories of each other. And that's when I've started to see the will shift of leaders within institutions. And so my strategy, and I think part of this, and it's not always safe to do so, is to tell, my own stories, and to show up in that way, but not everybody can do that in the environments that they work. And so Michelle, how have you used story? Because folks, you've changed the will of many people. I've seen it. Can you speak to that and what you think the secret sauce is in terms of changing the will of people to do differently, to give differently, to show up differently, to be with you, and to want to support a cause that they may never have been a part of or thought they were even to be a part of in the past?
Yeah, I think art speaks to everyone, right? It's subjective, and so I decided to use my art along with my family's history of advocacy, and my father was the first black prison chaplain that was appointed by George Wallace. He's still with us today, and so basically I just use those family dynamics when you talk about civil rights. My aunt, Aurelia Browder v. Gale, that ended the Montgomery bus boycott. So I'm just tying in the fight for human rights. We call it civil rights, but really it was a human issue. So when I'm speaking to you from my experience of living in the antebellum South, even though it's not antebellum. I mean, the mindset is still there. And so I just feel that the art, the Mothers of Gynecology, and bringing that story to life, and how that story has evolved in medicine is really changing the way people look at where we are in this country and how we treat one another. And I can't continue to, I have to drive that home, because it's about empathy, dignity, and respect. And of course, everybody is fighting for DEI, right? Well, you can't have DEI without EDR, empathy, dignity, and respect. That's right. So it goes hand in hand. So what I'm doing is being authentic and truthful, just like we had someone who said, we're gonna take the trash out in Washington, okay? They explicitly tell you how they feel, so I'm gonna tell you how I feel. I'm gonna show you through my art what has happened to Black lives, Black women, Indigenous women, Irish women in this country as commodified, and then, how it's been codified in our laws. Like, why are we not talking about this? Even in the laws, how people have been treated, and it's legalized, right? And so if I can speak to you in that way and show you, hence the red glasses, right? I want to show you this history through a different lens, and how it affects us today. And so that's my approach, and is to create my own lane. I live in Montgomery, Alabama, where there's this massive, the National Memorial for Peace and Justice, the Lynching Museum is how they kind of categorized it, right? And then you have these other sites. But what about the women? What about children? Why are we not talking about sex trafficking in the 21st century? Why are we not talking about, again, the maternal health crisis that we're having in infant mortality? And so if I can create a piece of art that will make you look at it and where we are today and drive it home, then I think my job here is done. And so that's what we're doing, and it's been successful.
Yes.
Can I just chime in
agree.
quickly
Of course.
on what she said? People feel stuck. So when I think of will and hearts and minds, people want to feel useful, People when they don't feel useful, it feels like they can't do anything, and then they just don't show up, which is what happened, last week, right? And so I think thinking through, and this goes back to the solutions conversation, this is where art can be powerful, because I think it can shine a light, but also open a channel in your own consciousness, right? When we're all stuck in kind of the status quo and the way it is, it's very hard to see past it, right? And so I think what people are desperately searching for is how to be useful, What are the solutions? It makes me think of like PTSD at the VA. I remember there was this HBO movie. I was at the VA at the time as a White House fellow. I think you were also in the administration. And I'll never forget this because that entire movie was about the problem. And everyone at the VA is saying, but wait a minute, we have solutions. We can cure PTSD. And no one really, that was such a moment for me, because I was like, yeah, some of the most cutting edge research, we can very much cure PTSD now. But you don't hear that, right? So framing narratives around and giving people entry points into being useful, into doing something about these problems, is very much the vacuum that needs to be filled right now, I think, to get to the next place.
Go ahead.
Yeah, I was just going to say, the points of how we need to evolve healthcare communication were just highlighted. This idea of empathetic communication. I think many times we as clinicians have been trained in terms of how to deliver either factual information or information. And many times we miss the dynamic of being able to engage our patients by both displaying vulnerability and empathy, but also being able to engage them in a way that then has them see us not just as the deliverer of healthcare information, but somebody who cares about them and cares about people. And so as we think through this context of, again, kind of how we evolve healthcare communication, I think there is a role for empathy, but there's also another role that both have heard of here is even multimodality. So, the power of art, music, and other forms of ways in which people feel mobilized and energized has to be a part of when we think about their overall healthcare journey, because something as simple as music is a part of many of our lives, right? And so the linkage between music, health, and all of those components, again, those are not fringe components of science. That is very much this idea of holistic patient care. So I think we're at a point now of this whole evolution of public health, healthcare, patient engagement, and I think a lot of it starts with the concept of empathy.
Absolutely, thanks for that. And we're getting ready, to wind down. As we go into our next space, and the two of you just kind of built on where I was going, and you can add to this, but just what would you recommend for those who are listening in, those who are in the audience here? What is needed? What do you need, actually? I want to ask that question. What do you need as you are doing the work that you do and the roles that you have in narrative strategy, cultural strategy? What do you need from people, from health providers and from the health community and all the other healers that are there? We'll start with who? Anybody want to start?
I think I encourage all physicians, all healthcare providers to start doing this narrative work and not to be so scared of it. There's so many amazing narrative practitioners and cultural strategists that are brought in, and I think we all have to be a lot smarter about not talking to the same people over and over again, to open up your circle, even if you don't know, open up these circles and invite people into them and have the hard conversations. It's gonna be messy, you're gonna make mistakes, but you're gonna learn a lot in the process. So that would be my invitation to those listening who are considering how to be useful in this space.
Go.
I'll say that the evolution of healthcare and public health and patient communication, I think we need to think, I'm a trained practicing cardiologist, and there's all different components of cardiology that's very structured, and there's stents and things that we do. Again, forgetting sometimes the patients that we put the stents into. And so I think the thing I think I would want to encourage the most now around where we are with healthcare and public health is to think through how we reach and engage people and have them being a part of their own lives and being a part of their own decision making. And so that involves the work of narrative building and patient communication. That involves the work of just sitting down, taking a deep breath when you're one-on-one with that patient and thinking about them as a human right before you deliver either very good or very bad messaging. And the whole concept of how we continue to evolve healthcare communication, whether one-on-one or at scale, involves this idea of thinking through people, culture, and again, where you started off with this idea of empathy.
Thank you. Babe?
Yeah, it's a hard question. I feel like I'm still trying to figure out what I need in this moment, honestly. I think one thing that comes to me is that one thing that we're looking for, anyway, I don't know if we need it, but we're definitely looking for it, is people, leaders from all positions, could be in communities, could be in movements, could be in professions, who feel as we do that the gaps that we see in health outcomes, educational outcomes, criminal justice outcomes is because there's a power arrangement that we're dealing with. And Michelle, your work gets so clearly to that to me. I mean, the way health inequity was created in this country and is maintained is a history of brutality and deliberate oppression, I think. And I think that for those of us that can engage in that conversation, we should. And we ought to be strategic about how we deal with that problem. Because it's not something wrong with patients. It's not, a technical problem. We think it's a power problem.
Thank you. Michelle, final word.
I'm gonna take y'all to church. Can I take you to church? I'm sorry, I grew up in the church. So my dad is a preacher, so I got a little bit of that. So what we say in the church is that, you have a charge to keep and a God to glorify. Okay? And so basically that means we all have a mission, a vision, and a purpose. And it's up to us to make our mark. And so upstairs you'll find a pair of, it's called the Met. Where's Emily? She told me it was called the Met. It's the hand holding the scissors, right? And it's for surgery, but the Met was used to pull back, to dissect and pull back the tissues in a patient. So my charge for you all to keep is to take your Met and pull back the tissues, because there's layers to this thing. It's systemic racism. This thing was already created and it's been maintained. So how do we pull back the layers? So that's your charge. If you see it, what do they say? If you see something, say something. Remember when we were younger? If you see something, say something. It may cost you something, but it's worth it in the end, because someone will be freed from the truth that we share. So that's my sermon for today.
Thank you. And on that note, we're at the end. Good thing, because I'm about to start golfing. I want to thank you all for joining this conversation. I want to thank you all for who you are. I've known you all for a good part of my career. I thank you all for always being present, showing up, being responsive to the work that we have all done collectively. To me personally, the work of building all these centers and offices of minority health over time, and to me as an individual as well. You all have shown up for me really in deep and tremendous ways, and I appreciate every single one of you. Thank you, and thank you. Thank you to the artists. I know Lalu, it's here, it's complete. This is actually we have two of our board members here. If you could just stand up real quickly, that would be awesome. They're going to help us, I know. Yes, thank you for being present. And that's really important, right? From the context that we have our highest level of leadership here present with us today. But I know we're going to have this piece of art somewhere, this wonderful piece of art in our AMA space, because what I've found is actually there's a lot of presence of art within the context of medicine. We have a wonderful collection already in the building, and so we want to make sure it's representative of all the different ways of how we can express art. So very excited about that. Thank you, Lalu, for your energy and for your space and for doing this for us. We want to hear your thoughts about our conversation today. There's going to be a QR code that probably comes up. There we go. A QR code. Please, if you have some time, please do the survey. for healthcare professionals. Again, you can get your CME and CE credits. There will be a recording of this conversation as well as a visual summary. Again, thank you to our speakers, ASL interpreters, our artists, and everyone in our audiences. I want to thank my team. You all are amazing, amazing, amazing. Have always held me up and have kept me propped up in doing this work, so thank you. So we're at the end of this, and I want to thank everyone in the audience, everyone who supported this work. I've been here for 5.5 years, and it's been an honor to be part of, this legacy of supporting the health of our people in the context of being a Black people, our people in the context of being an American people and being part of this world as people. And so I really just wish for all of us, as we embark on this next phase of our existence as humans on this planet, I think for some of us, we're very clear that the work is going to become real very soon. And for us to keep this context and the importance and prioritization as much as we can of rest and as much as we can of joy, and to always remember that we deserve our dignity, the respect, love, and the opportunity to experience joy as everyone else does. So thank you, and thank you all again for being here today.